Okay, guys. Well, thanks so much for coming this evening. I know it's late and early for some folks, depending on where you are. We're really fortunate to have a fantastic panel of folks here today. Just would love to introduce them here in a second. But first, I just want to mention a quick change in the program. We're super fortunate. Dr. Gross was not able to make it, but we're super fortunate to have Alice Lynn here moderating for us today. And then in addition, we may, if we're lucky, be joined by Cecilia Schmalbeck from Temple University, which would be wonderful. So we've got an all-star cast here today. Just another quick reminder, January 7th is going to be the next virtual tumor board. That one will be on multidisciplinary management of salivary cancer. So that'll be moderated by Andrew Holcomb. So really great session as well. It'll be right after the holiday, but hopefully you all can make it. So without further ado, we're going to be talking about non-melanoma skin cancers today. And like I said, all-star cast. We have John Harper and Ann Kane, who everybody knows is associate professor and surgeon scientist at University of Alabama. Thanks for being here, Ann and John. And we have Rich Bavir, I didn't mispronounce it, Bavir, and Marcus Monroe joining us from associate professor and division chief at University of Utah. And then we've got Soli Torres and Doran Aldabe coming to us from an MD, PhD, and assistant professor at MUSC, who are just finishing up a free flap, so hopefully they'll be able to make it. Um, of course, everybody knows Alice Lynn, fellowship trained head and neck surgeon and known for her fantastic recons. I've been able to witness a couple of these myself, and many times over in talks, I'm always amazed. I'm always impressed at from Kaiser Permanente at Southern California. And then, of course, if Cecilia Schmalbeck does jump on, I'm not sure if she's on, but if she does, everybody knows Cecilia coming to us from Temple University, certainly a big name in non-melanoma skin cancers. And so we're really lucky to have this whole panel here today. So I'd love to turn it over to Alice now, and really excited to hear about these cases. Thanks so much.
Thanks, Brittany. Thanks for the introduction. I don't know if I heard that one before, but so let's start with our first case. John Harper, you wanna go ahead?
Yeah, let me just. Is that sharing now?
Yep.
Okay.
Yeah, you're there.
I'm John Harper. I'm a neck fellow at UAB with Dr. Kane, and I'm going to present a patient that we took care of a couple of weeks ago, and kind of fits the topic perfectly. So this patient, TY, was an 80-year-old male. Originally referred for recurrent squamous cell carcinoma of the left cheek. His medical history, he's got end-stage renal disease, was on dialysis, chronic anemia. He was a diabetic and then had some osteoporosis. Overall, kind of frail, not healthy, and also not a healthy 80-year-old. Social history, he was a former smoker, quit several years, and then denied any other alcohol or substance abuse. Surgical history, he had a previous Mohs excision of his nasal tip back in 2023, which was squamous cell carcinoma. This was reconstructed by an outside surgeon with a paramedian forehead flap. He was mostly followed with like a medical oncologist and dermatologist. Developed a lesion over the left maxilla in around spring. It sounds like he kind of left it grow a little bit until it started becoming more painful, having some drainage. And that's when he saw his outside provider, and the medical oncologist had kind of concern for recurrent squamous cell. So they started him on pembrolizumab in July. And after about 2 doses, there was concern that he was continuing to have progression of disease despite the immunotherapy. And so that was when he was kind of referred to Dr. Kane's clinic for evaluation. So that was kind of the first time we were really involved in his care, was after he had already failed immunotherapy for his recurrence. This is kind of just a picture rather than describing what was seen. This is kind of what he came into clinic with.
So Dr. Harper, before you
Yeah.
keep going. So is it the thought that this is a recurrence from the nasal tip cancer, like a peripheral recurrence from the nasal tip cancer?
Yeah, and it sounds like when they originally did his Mohs surgery, it actually went somewhat intranasally.
Mm-hmm.
So that will kind of fit with maybe this was some recurrent squamous cell that had then grown underneath into the maxillary sinus and then protruded outward. which is why it maybe got missed a little bit. And he also had kind of that drainage congestion symptoms.
Mm.
Uh,
And then how important is it for you to go and get the original pathology for the Mohs and the details of the Mohs?
so I didn't see this patient in clinic. I know, I think knowing the fact that what they saw during the procedure, like did it go intranasally or would this be a separate primary site, knowing kind of what their surgical excision was, knowing did they have close margins or aggressive features and that kind of thing could help me say, okay, well, is this a recurrence or is this uh, another primary, especially given his age and location for skin exposed, sun exposed skin. Um, but I believe the concern from what was referred over was that this was a recurrence,
Mm-hmm.
given the close proximity to his previous site within about 2 years. So,
Yeah, we did our best to try and get his original records. The family actually had photos of his Mohs, which he lost his ala, the defect went intranasal, and then also deep in the cheek skin as well. But we weren't able to obtain the outside records. But John, otherwise that was perfect. I think he definitely had some high risk features that probably would have needed adjuvant treatment originally.
Right. Okay, let's go on to imaging. It looks pretty extensive there.
yeah, so next step was imaging, getting a CT scan on the left and then MRI. I couldn't get the videos to work, so I just put in kind of some representative imaging. But um, biggest things to note here was that the concern around that periorbita on the left. Um, so discussion with him regarding reconstruction options, as well as the possible concern that that left eye may have to be removed prior, just to kind of discuss with the patient before surgery.
Can I ask the rest of the panel if there's anything else on that imaging that looks concerning? Dr. Monroe or Dr. Adebayo? Oh, I don't think Dr. Adebayo is on. Dr. Monroe, anything else about this imaging that's concerning to you?
Yeah, I'd be quite suspicious and want to see the MRI sequences, particularly around the base of the skull. At least on the axial CT scan, the pterygopalatine fossa looks okay, but you see how the tumor kind of dumbbells through the front wall of the maxillary sinus and is centered around the inferior orbit. Would be a picture that's very consistent with perineural invasion spread from a cutaneous squame. So want to pay attention, particularly around the skull base. That is where we run into problems with the ability to clear the patient. Um, this is an interesting case, I think, and maybe we'll get to this discussion, but in the evolving area of immunotherapy, and this patient had a couple doses of immune therapy, but certainly when we're talking about orbital preservation, that's something that I think when we talk about immunotherapy, that's where a lot of people are starting to use it. And just a point I'd like to make is that it's a little hard to know after 2 doses or not if the patient really responded to the immunotherapy. So just be, if he's obviously clinically progressing, then I think you have to go. But failure to respond after 2 doses is really not a failure on immunotherapy since the median time to response is in the 2 month range.
And then this is a good time for me to ask you, Dr. Monroe, and also Dr. Kim, what kind of surveillance do you do during the the neoadjuvant immunotherapy treatment for the patient? Like what kind of assessments do you do?
Yeah, so I think it brings up a point to try to clarify between what is neoadjuvant therapy and what is just systemic primary therapy with immunotherapy, right? If in a case like this, if you're talking about an approach with immunotherapy, traditionally we like to think of resecting the entire extent of what we had before, but if your goal is preservation of a critical structure, that's really not possible. So at least in my practice, at least with patients with orbital invasion, if this patient would have gotten immunotherapy, he probably would have been followed clinically and not had surgery unless he had evidence of progression. And that usually is scans on an every 3 month basis is how it works at our institution. Understanding that the correlation between radiology and pathology is, not the best, particularly in cases where you think you still see some residual scar or mass, but it hasn't grown any. The imaging is really not reliable at saying if there's visible tumor. If the tumor's expanding into new areas or progressing, that's pretty concerning for the actual disease progression. But they would be monitored every 3 months until progression, in which case they would be deferred to surgery. If we're talking about a neoadjuvant approach, similar to the NRG HN014 study or Neil Gross's neoadjuvant study, we would usually image them sometime around 2 to 3 months, although that's not always consistently done, but certainly they would have a visit to make sure they're not progressing clinically.
All right, and then let's continue with the presentation.
Yeah, so next step for him was a trip to the operating room. He had a wide local excision, maxillectomy, partial rhinectomy, left neck dissection, and was reconstructed with an ALT free flap for soft tissue reconstruction. The pathology report from that surgery is over there on the right side of the screen. Basically, it was a T4N0 M0. He did have LVI and PNI seen on his pathology report. His hospital stay overall was pretty inconsequential for his medical history. His biggest issue was mostly just getting rehab placement. So that kind of kept him a couple extra days just until a rehab accepted him. So he was discharged on post-op day 9. He was seen back in clinic and was discussion for adjuvant radiation due to the perineural invasion. And like you had commented on before, that V2 nerve margin was negative intraoperatively from our resection. And also,
Dr. Harper, can you tell us what was the extent of the neck dissection you did for this case?
For his neck, I believe it was level 1, 2, 3, and 4. I believe it was 1 through 4 for his neck.
And was the rationale for that just because you guys did a free flap reconstruction here? Or do you routinely do that for T4 skin cancers?
I think the main rationale was, one, given the size, and then since we were looking for vessels as well for the reconstruction, but because it was such a large and recurrent doing the.
He had and Jeb may not remember this, but he also had a PET avid node that was kind of borderline FDG activity in level 1 as well. So it was somewhat for the obviously the size and the location of the tumor and the fact that we were doing a free flap, but he also had a borderline FDG avid node.
Okay. I mean, I'm curious to hear from all the experts on this panel. I see that Cecilia also joined us. If we've changed anything about the extent of neck dissection for these skin cancers, especially in the age of adjuvant immunotherapy, where we might be giving some adjuvant immunotherapy. Any comments from any other experts?
Alice, this is Cecilia. I missed the beginning presentation, but what a great case to drive home. And in fact, just today we had this discussion in our protocol meeting that, patients that are oftentimes, right, they're PET positive, not FNA proven nodal disease, but we radiographically and clinically label them as N positive. And then they go through the neoadjuvant treatment and wind up, having their neck dissection and have 0 positive nodes. And we do know there's always sampling error with that, right? Usually the node's bivalve, but I do think with time we're going to learn who do you really need to do that neck dissection on, and when can we just follow it. And my comment was we really are kind of writing history as we go along. So I'm very grateful for this tumor board and everyone else that's sharing the information.
Yeah, I always wonder, do I try to limit my neck dissection so there's more lymph nodes in the area? And that's something I've been debating in my mind. I don't know if anyone else has any other comments on that. Okay, well, we'll see what the future holds. Okay, and then you want to continue your presentation?
Yeah, so he was seen back in clinic as having discussions for starting adjuvant radiation therapy. So his kind of story is continuing to progress. We'll see how he kind of does in further follow-up. Big reason to discuss this case was the recent trend of immunotherapy in this patient's care. Really, it was after he had recurrence and after starting immunotherapy with the outside medical oncologist before any kind of surgical input was put into his case. And so kind of with the trend kind of taking the surgeon out of the discussion and leaving it to like medical oncologists and dermatology for these cases, like how are people trying to maintain their investment in like staying involved in tumor boards and things like that, especially if you're not at an academic institution where you may not meet with the medical oncologist about all these patients to discuss it. And then another issue was we did an ALT free flap for him rather than a bony reconstruction. And so kind of some people's thoughts on reconstruction in patients with multiple comorbidities or elderly patients, kind of trying to take a least morbid approach as possible for their reconstruction. And then some other thoughts were just kind of, he had the 2 doses. Would you continue immunotherapy after his surgical excision in conjunction with radiation therapy? Or how do you kind of manage his further post-operative care and his further workup and kind of make sure he gets treated the best possible way?
Great. So, on your MRI, we saw there are some changes in the orbit and the periorbita, but then intraoperatively and ultimately found that there was clear, or what was the finding there?
Yeah, so it was able to be kind of taken off of the periorbita and margins were sent, and it was kind of at the bottom here, that periorbita margin was negative.
I see.
So
Okay. Dr. Monroe, you mentioned that for like immunotherapy you consider immunotherapy if you can maybe sometimes save structures. And in this case, not that many structures were able to be saved, but do you think there's any other advantages to the neoadjuvant immunotherapy we should highlight?
Yeah, I mean, I think that adjuvant immunotherapy is part of the discussion now for patients with advanced cutaneous squamous cell carcinoma. And unfortunately, the data is a little mixed. So the current published trial was the C-POST trial. That was a positive trial that looked at adjuvant immunotherapy following surgery and radiation for high-risk cutaneous squames, and that demonstrated an improvement in disease-free survival, a pretty significant improvement. The concurrent study, the Keynote 630 study, which hasn't been published yet, was actually a negative study, though. So that there's a little bit of clouding of the data since we have 2 studies. But overall, I think where we start to consider is any patient with advanced disease, and particularly in patients where the benefit seems to be looking at the data from those 2 studies in patients with N3B disease, so significant extranodal extension. That's probably where we consider it. We offer it to patients, but that is where we probably feel the data supports the benefit the best.
And would you strongly recommend radiation therapy
Yeah, I
post-op?
think the standard of care is absolutely still radiation therapy. That would be an absolute kind of recommendation in our group, and then discussion of it, and a stronger push for it if a patient had significant nodal disease with extranodal extension.
And Dr. Kane, do you want to talk about why you chose the ALT for the reconstruction for this case? It sounds like he was a pretty sick guy. Anything
Yeah.
else?
Yeah, he was definitely a more frail gentleman. And the other factor, I think, as well, was the fact that he was end-stage renal failure on dialysis. And there is some evidence that you have higher risk of free flap failure in that patient population. So kind of just putting those 2 things together, I'm a little bit more hesitant to do a bony reconstruction in a patient like that, where the recovery is going to be more extensive. They are more frail. They're more likely to be in the hospital for a longer period of time, have more complications anyways. And then with a higher risk of flap failure as well. That was why we decided on a soft tissue flap for him.
Mm-hmm.
And his main goal also, which I think is also important to talk about with the patient, right? His main goal was to be able to eat and if possibly, to be able to save his eye, right? Which we were luckily able to do because the tumor wasn't invading. We were able to clear the periorbita, but his main goal was that he wanted to be able to eat. He was not as worried about a cosmetic deformity. That also just kind of fell in line with doing the ALT.
Okay. We have a question from Andrew Prince. Can you speak to the role of neck dissection and cutaneous squamous cell, please? Neil Gross had a paper from 2023 that does not suggest it, but then the Brigham and Women's staging suggests it in higher stage tumors. I think we did kind of talk about that, and this is something that in my mind is evolving in terms of elective neck dissection, but I think for this case, it wasn't necessarily elective since there was a PET positive node. Okay, great. Great discussion. Let's go on to the next case. Thank you, everyone. Thanks, John. Harper, and thanks, Dr. Kane.
Yeah, thanks for having us, Alice.
Yeah. If you stay on, I'll ask you more questions, Anne.
I do have to drain a neck abscess, but I will, I'm just gonna go off camera, but I'll listen.
Okay, okay, wow. Everyone's super
Sorry, I
busy
have
these
a
days.
patient with like
That's okay.
mediastinitis and stuff that's
Yeah,
I
no,
just get to sleep.
you should drain the
Sorry.
neck. I agree with draining the neck abscess.
Thank you.
Okay. All right. Dr. Bavier,
Can everybody see my slides okay?
I can see them.
Perfect. So thank you for your attention today. I'm Rich Bavier. I'm the Head and Neck Oncology Fellow at University of Utah Huntsman Cancer Institute. I have the privilege and pleasure of having my mentor, Dr. Marcus Monroe. And so I'll be presenting an interesting case we had on dermatofibrosarcoma protuberans. All right, so this patient is a 46-year-old male who actually presented to our PRS colleagues for a progressively enlarging cystic mass of the left frontal scalp. He initially noticed it after having some trauma to the area during his work as a roofer. And for essentially about a year and a half, it had been progressively enlarging until it was the size seen here. Had no relevant past medical history, so our PRS colleagues actually took him for an excision with the assumption that this was a post-traumatic cyst. The initial resection, they just did kind of a close resection. Final pathology showed that this was, in fact, dermatofibrosarcoma protuberans, measuring 9 by 8 by 5.2 centimeters with tumor present at the margins. On the right, I'm sorry, on the left, you can see a post-op photo of his healing scar. Given his positive margins, a post-op MRI and CT scan were performed, which showed only post-surgical changes of the wound bed. And he was ultimately referred to our multidisciplinary sarcoma tumor board for treatment recommendations.
Dr. Bavier, was this removed without removing the skin?
So a large section of the skin was removed. It kind of acted as its own tissue expander. And so you can see they were able to primarily close it. But an area that they were concerned kind of was adherent was removed as well.
Okay.
So at the tumor board, the cancer was stages 2B. And there was really kind of two schools of thought. It should be noted we're actually not a part of the sarcoma tumor board that they met with. And so some members felt that re-resection at that time with wider margins or 2 centimeter margins followed by radiation and possibly imatinib immunotherapy was warranted. While others were actually recommended deferring definitive treatment and proceeding with just close surveillance until local recurrence had occurred. This was discussed with the patient, and ultimately they opted for just close surveillance with serial MRIs every 3 months. He was also instructed to represent if he noted any concerning clinical changes. And he did quite well for almost a year, 11 months after his initial resection with PRS. The patient's MRI showed multiple T1 hypointense and T2 flare hyperintense lesions of the left frontoparietal scalp. The largest was measuring about 3 centimeters, concerning for recurrence. An FNA core biopsy was then performed, which showed CD34 positive uniform spindled cells infiltrating skeletal muscles, confirming that diagnosis of recurrent DFSP.
So, I know you weren't a part of the original tumor board, but Dr. Monroe, would you have recommended re-excision at that time?
Absolutely.
Yeah.
This is one that you just the kind of point here is especially on DFSP, like there are some tumors that margins, maybe adjuvant treatment, we get away with it in cutaneous squam or basal cell carcinoma or other skin malignancies. This is one where positive margins at a lesion of that size and where they preserve that much of the skin, you just know that this is a tumor that's going to come back. And we'll see actually from some of our kind of subsequent management here that some of the patient's decision making kind of drove this. So it's a little hard to criticize, but I would have strongly pushed for a resection, and we'll see that even when this did recur, kind of the my initial recommendation, which was to widely excise the first time the entire area, the patient was really reluctant. So I think part of this decision making was driven by the patient.
Yeah. Um, I agree. And I also worry that it comes back and starts going into the bone and becomes more complicated. And these take
Yes.
so long to come back. You sometimes lose the patient until it's like way too late.
Yeah, he's going to have
Yeah,
time frames of recurrence. I've seen that a decade later, so it's a long time that you have to watch these patients. I usually watch these patients lifelong.
yeah. Okay, so what do you guys do then?
Yeah, so that's a good segue. It was at this point that he was actually referred to our team. He, had no clinical complaints on exam. He had a well-healing L-shaped scar from the left frontal hairline down to the mid-forehead. There was some palpable fullness kind of at the superior and inferior extent, but it was all freely mobile without any, concern for connection to the underlying bone. Additionally, had symmetric brow movement, intact sensation, no palpable lymphadenopathy or other lesions. Given his recurrence, as Dr. Monroe already kind of alluded to, we recommended kind of wide local excision with free flap reconstruction. And he was pretty hesitant about that and really wanted us to kind of proceed with as conservative of an excision as possible. And really the risks of this, being persistent or recurrent were explained to him, and he really wanted to just go with a conservative approach. So for surgery number one, we just did essentially a gross total resection with 1 centimeter margins from the palpable edge. Intraoperatively, the mass was actually noted to be a lot more extensive than preoperative imaging would suggest, and it extended from the contralateral side, from about the right mid-brow all the way over to the temporal line. And so, in accordance with the patient's decision-making, gross total excision was performed, but positive microscopic margins were anticipated. Gross pathology showed, we excised 8 by 5 by 1.5 centimeters, of which there was multiple areas that were positive for DFSP, the largest of which was 3 centimeters by half centimeter and a half. Tumor was present at the inked margins. And it was at this point, at his first postoperative appointment, we discussed these findings. We kind of went over things, and he agreed to proceed with a wide local excision with a lat dorsi free flap reconstruction.
Yeah, I think that one of the points that I think this really makes is that DFSP is usually underestimated on imaging.
Yeah.
And even in a case where it's a non-recurrent, these are ones where, you need to plan kind of large margin based surgery, because margins, as is kind of a little bit more important for sarcoma, things in the sarcoma field are just much more critical. But this was one where we kind of had a high suspicion that we were going to be proceeding to this kind of next step, but just had to kind of prove it to the patient. And so I think in a situation like this, the other thing, if a patient's not there, um, don't do anything to burn your bridges and make your subsequent attempts at excision harder. So one of the things, his disease was pretty extensive, and we could have at this initial surgery, gone much more, but knowing that we were going to recommend, really the standard of care would be to come back and excise. We left the periosteum just to make sure that the plane was going to be preserved over the bone for his final resection. We didn't do anything that was going to compromise our ability to give him the definitive treatment that he really needed.
Any thought to delay the reconstruction? Just leave it open?
Mhm.
Yeah.
Yeah, this is one where we just kind of this wasn't the final surgery, but yes, a lot of times we will for things that are a little bit harder to clear pathologically. So things like spindle cell tumors where you have frozen artifact or things like melanomas are frequently things that we will delay.
And anything you do to the wound while you're delaying the reconstruction? Do you use Integra? Do you use any like dressings or?
Yeah, I've gone away from Integra to completely synthetic, the BTM, just because I think the Integra has a little bit higher rates of infection.
Mhm.
So I do usually use in melanoma or anything where I'm delaying it, I sew in a BTM graft. And I used to, when I started practice, just put on like a zero foam bolster, leaving the wound open, and you get a lot of inflammation. If you sew in a BTM graft and come back, the wound is actually usually pretty clean with minimal, within a week. If you come back within a week after ask your pathologist to rush it if they can't get it
Mhm.
sooner, and then usually the wound is much cleaner than if you would just put a bolster on.
Great. I gotta look that one up. Okay. Is there any more to the? Okay, great.
Yeah, so about a month later, he went for the definitive treatment, the Y local excision with larger margins, and reconstruction with a lat dorsi. Um, it should be noted we did a muscle only lat dorsi with a split thickness skin graft over top of it. Final excision was 12 by 11 centimeters, and all circumferential margins were negative both intraoperatively and on final pathology. Postoperatively, he did really well. He had a completely uneventful postoperative course and was discharged on post-op day 5. Like I said, gross path, was 12 by 8 by 11. It was multifocal disease. The largest lesion was close to 2 centimeters, and all margins were negative. They did call a deep margin as close. It was, a millimeter within the deep margin, but we were, peeling this off of periosteum.
Yeah, we
And then the
took the
closest,
periosteum. Yeah, yeah,
I'm sorry, took the
yeah.
periosteum.
Always, just general oncologic principles on these. Always try to take a layer beyond the tumor, and
Yeah. And then the
And then,
periosteum was clear. Okay.
periosteum was clear. Although, in a revision case like this where you don't know what they did and they're scarring, there's always the question. So
Mm.
recurrence, large thing, we still recommended adjuvant therapy afterwards for this gentleman.
The reconstruction looks awesome. What if the margins on the second surgery were also positive? Let's say at the brow. Would you?
Yeah, so if they were positive at the brow, we would talk to them about further resection there. We did kind of intraoperatively clear our margins of our supraorbital nerves kind of at the foramen just to make sure we didn't have any obvious perineural tumor spread. I think that and it depends if it was that in isolation and not other positive margins, it makes a lot more sense for going in and re-resecting. If you have that and you have either multiple other, peripheral lesions that you just can't see peripheral margins, or if you have your deep margin positive that you can't re-resect, then and there's more morbidity for resecting, it doesn't make a whole lot of sense to me to go back in. So it kind of depends on if that's the only site of disease, if we would recommend re-resecting or not.
And if you couldn't re-resect, what would the considerations be? Radiation therapy, levac? What? I
Yeah.
have very little experience with this
Yeah,
tumor.
the targeted therapies we usually reserve just for disease that cannot be treated with surgery and radiation, just because we feel like for most malignancies, these included, the chance of recurrence is pretty high with those things. The durability of control is lacking, so
Yeah,
we don't usually do that unless surgery and radiation aren't an option. So this patient would have been recommended radiation therapy.
yeah. Um, one question that Dr. Magnuson brought up for the last case we didn't get to was about concern about the proximity to the orbit for the last case, and I guess for this case, if we were to get radiation, how it could affect the function of the eye. Does anyone else on the panel want to give any comments on that? Dr. Schmalbeck, would you? Is there?
Yeah,
I guess, yeah. Sorry. Go ahead.
yeah, no, it's a great question. These are challenging, and I want to also acknowledge, I appreciated Dr. Magnuson's comment about NGS. I will disclose, similar to him, I don't have firsthand experience with imatinib, but I know that that is used systemically. So certainly that's where I would lean on my medical oncologist. Again, if we thought it was going to wind up requiring an orbital exoneration. The other thing I will say that I found helpful, these are very, very hard to clear. And so I often will have my Mohs surgeons, for example, in that area by the brow, if you're worried about the lid, actually do Mohs surgery to find me where the final end of the tumor is. And then I'm going to go and take a much larger margin beyond that. But I've really appreciated the partnership with dermatology for some of these challenging cases too.
That's a great point. That's a great point. I never even thought of that because usually when they go to Mohs with a huge tumor, Mohs is like no. But if you just need them to clear one particular area, that I haven't thought about that, but that sounds like a great idea.
Yeah, we'll do things similar. We didn't do it in this case, but sometimes similar with other tumors where we will just take a double-bladed scalpel and just define the periphery of what we're going to resect. And you can take that margin, under local all the way around down to the bone and just, do a running stitch around it and have your pathologist clear it. If you want to avoid, 2 trips to the operating room, that's something that occasionally we use for kind of complex, hard to clear margins.
Yeah. Yeah, I've never done that. I've heard of that, and that's a great point. All right. Is there any more of this case presentation, Dr. Bavier?
Yeah, so
Okay.
he just underwent radiation, got 60 gray, and then is following up with us yearly for kind of continued surveillance. These are some final pictures of him as well, which, as you can see, he really healed up fantastically.
Yeah, it looks great. What's the rationale for the radiation? The close margin?
I think just in general, based on how it was multiply recurrent, how difficult it was to clear, and just the ultimate stage of it, I think pushed us towards radiation.
Yeah, part of the concern and difficulty is I'm not the first surgeon and I have a very broad interface with the skull and margins that are close, within zero point 0.1 millimeter is I view that as a high probability that there's probably some point where, the tumor is microscopically positive along that deep margin, especially if it's a recurrence like this with prior surgery and violation of tissue planes. So, I
Yeah,
think something like this, it's you could go either way. Our tumor board discussed that, but that was the rationale.
I agree that if you've gone to the max that you want to go to and you felt like you did a pretty good job, there, I would also send this patient for a radiation evaluation. Okay, great. I think there is NGS sometimes can be used, and there is a response to Gleevec for a lot of these tumors, but I think that they're not usually curative, right? Yeah.
Yeah, that's correct. There are a bunch of TKIs that potentially have limited, use in addition to Gleevec that have been studied, but again, yeah, they're not curative. So
Okay, great. Any other comments about this case? Great case. I'm still waiting to really take care of one. Um, okay, Solimar, Dr. Torres.
Hi, everyone. My name is Soli, and I'm the fellow, one of the two fellows at MUSC. Dr. Adelbay, sorry, he is still under the microscope, so it'll just be me. He's very sad to miss it. But we do have an interesting case for you all. So this is a 70-year-old with a slowly growing right lower eyelid skin lesion for several years. He has a medical history of multiple non-melanoma skin cancers, squam and basal cell, like in the ear and the chest, all treated with surgery. Hypertension, AFib. He's a former smoker, not super significant. No alcohol. He worked in construction, so significant sun exposure, retired, no immunosuppression. on physical exam, we have this lower eyelid, mostly lesion, some of the upper eyelid as well, erosive, and it's fixed to the bone. The skin does not move. However, when he stretches his eye open, he says that he can see. His extraocular muscles, his extraocular, movements are hard to examine, but seem impaired. And a clinic biopsy was done that showed that this was basal cell carcinoma.
So the eyelids are not functional.
No.
There is some function of orbital movement, but it seems impaired. So does he have diplopia?
Yes.
Okay. Let's see the scan.
Right. So this is a MRI at T1 post contrast. Just gonna let it run. No, let you guys know what the radiologist saw. So this is a 3.3 by 2.6 enhancing mass center in the right medial canthal region. There's posterior extension into the retrobulbar extraconal orbit, which laterally displaces the medial rectus and the globe. And there's a loss of plane between the medial rectus and the tumor. There's the coronal view. Frame scan. There's inferior extension to the orbital rim and lacrimal canal. Superiorly, it's close to the superior oblique, but there's no evidence of the supraorbital foramen or infraorbital canal.
So what's the preoperative evaluation you guys did for this patient? Or what's the evaluation that you guys wanted for this patient at this point?
I'm sorry?
What are the things did you guys send him to ophthalmology?
Yes, he went to ophthalmology, and I guess I kind of wanted more too, so this is just kind of like the key findings. He was in my ophthalmology, and then we're gonna present him a tumor board, I guess. But I just wanted to stop there and see what people might want to do.
I agree with you. I think definitely multidisciplinary tumor board to discuss. Maybe Dr. Monroe, you want to start with what your considerations are at this point?
Yeah, so these are ones that always generate a lot of discussion at our tumor boards, mainly because there are multiple options, and I think there are a difference of opinions, and certainly at least at our tumor board. But this would be a patient who would be a candidate for either, I would consider the standard of care for basal cell carcinoma to still be surgical resection and adjuvant radiation therapy. Understanding that the morbidity, at least of what you're showing, at least in our hands, would be an orbital exoneration with that degree of orbital involvement. And a high chance for adjuvant radiation therapy afterwards, given that it looks like it abuts some of the bony margins that may or may not be able to be easily removed. Short of that, he does have, I think, primary radiation when you have a tumor abutting the eye is likely to leave you with a non-functional, painful eye. And so that usually is not, for a tumor like this, would not be a first choice at our tumor board over surgery because it would, our experience is usually it kind of leaves the patient maybe even worse off than an orbital exoneration with hard to control pain. And then systemic options of vismodegib or sonidegib, so the targeted therapies. And then if the patient were to fail that, he would then be a candidate for immunotherapy as a second line. That's currently how it's FDA approved. And I think most of the discussion would be around do we start systemic therapy with a chance of orbital exoneration? And this is where the difference in kind of the surgeons, where we would say, hey, there's the studies that have been published show these 50 to 60% response rate, but that's not cure. That's not long-term durability. We actually have very limited data on long-term durability, and we have that with both surgery and radiation and the combination of that. So that would be the discussion at our tumor board, but probably with the number one choice of surgery and systemic therapy if the patient chose to not be willing to lose his eye.
I wholeheartedly agree, but I have a confession. Oh yeah, and then this is I know no evidence, but this is really quick. This is from the NCCN guidelines, and they say that systemic therapies like should be clinical trials, but there is an option of vismodegib and also cemiplimab as well.
Uh,
From
what
a
about what about neoadjuvant systemic therapy?
yeah, that's the first row. Uh,
Dr. Schmalbeck or Dr. Morrow, do you guys do any consideration for neoadjuvant systemic therapy for this case, or just any basal cell that's extensive and would be have morbid resection?
I can say our approach would be very similar to Dr. Monroe's group. When it comes to orbital exoneration, that is just so devastating to the patient. So we will trial systemic therapy, and it's very interesting. And I'll be curious to hear from others amongst our medical oncologists. So it's important to realize right now you have to fail a hedgehog inhibitor before you can go on to a cemiplimab in order for you to get most insurances to pay for the cemiplimab. Most medical oncologists, at least in our group, will argue that the hedgehog inhibitor is really palliative in nature. But we have had some success with that, and cemiplimab in definitely shrinking down the tumor and have been able to actually save an eye. Of course, we're watching those patients radiographically very closely because it's not like you can go back in and biopsy the eye to make sure it's all disease free. But have had some success there, and it's just I'm always humbled by how patients appropriately choose the route of treatment. So certainly surgery is standard of care, even with the orbital exoneration. That said, I've actually had some patients that have elected to have primary radiation, and they know they have a non-functioning eye afterwards, but there was something mentally about losing that eye that they just were not willing to go through. So it really does take an entire tumor board to handle these very challenging cases.
Yeah, and one point about, I mean, one of our hesitations, at least at our tumor board, at least the patients we see with advanced basal cells that have progressed this far, right? Typically, this is a slower growing disease, is that they've been ignoring this for a long time. And these are patients that sometimes are very easily to lose to follow-up. Vismodegib or these targeted agents, either with the dysgeusia or other side effects, are actually not well tolerated long term, and we do have some concerns just because we've had experience with this happening of patients getting lost and then they come back, years later, and now it's maybe, intracranial, or you're talking about a different extent of surgery. So just kind of that's always in the back of my mind with this particular patient population, just because usually they've ignored something for a really long time for it to get to this point.
I agree about vismodegib. I really don't like it, except for very elderly patients, because and I think even the palliative trials, the longest tolerance is about 2 years. And there is some data on neoadjuvant vismodegib, but the results aren't durable, meaning that even though the tumor will shrink before surgery, you do the surgery, the recurrence rate is actually pretty high. I think it's like over 30%. There is a trial, I think, going on now at Jefferson looking at neoadjuvant um, cemiplimab or PDL inhibitors for basal cell. I don't know about any results for that. I'm interested to see what that looks like. I have tried it on a couple patients who, and like I know, like you have to pay for immunotherapy, but for some insurances, also the vismodegib is extremely expensive because it's a daily pill, and some people have to pay like up to $4,000 for it. Okay, so sorry, I didn't mean to interrupt you, but I just wanted to add those points in.
Okay.
Olimar.
Yes. So actually, that was a bit of a lie. I just wanted to start the discussion. The patient actually came to us. I don't know if you remember the pictures, but there were some radiations. He actually received vismodegib and radiation 2 years ago. I don't know, outside institution, we don't have the details of what order that was. He went to ophthalmology. And these is his visual fields. So he just has light perception only. He doesn't really have useful vision after the radiation. So exactly like Dr. Monroe was saying. So at this point, this is now a very high risk, locally advanced basal cell carcinoma. mostly because of the location and size we know well, but also because of the previous treatment. It failed previous treatment. It's persistent after radiation. Okay, so new treatment plan after knowing this. Orbital acceleration.
I think you can go on with this. Yeah.
The orbital acceleration, which should be done anytime there's like significant involvement of the periorbita. For example, orbital fat, extraocular muscles, optic nerve. So yeah, he got a right orbital acceleration, repair of a small CSF leak from the orbital roof, and a reconstruction with a 10 by 10 centimeter cutaneous radial form, free flap. The surgical pathology was basal cell carcinoma, invasive skeletal muscle, no perineural invasion, and margins were clear. That's him post-op.
So actually, I meant to ask you, but we kind of got sidetracked by something. Did you guys have a CT scan pre-op or just the MRI?
I think just the MRI.
Okay. So I think for me, I like to have a CT scan, especially for superior orbital tumors, including skin cancers, because it's nice to see the proximity of the cribriform, which is that's probably where you had the CSF leak, right? Yeah, and then also just to see the bone, because some of the orbital bone can be quite thin, and you might end up in dura before you know it sometimes. Or you can enter it with just any instrument, like the back of any instrument. Did you guys remove any bone, I guess bone around that area, right? So it was a cranial facial resection as well.
Yes, minimally, but yes.
Okay. And how did you guys repair the CSF leak?
Just some fat, some TCL.
And you just did it yourselves? Wow. Did you have neurosurgery involved?
The surgery came and they put a lumbar drain.
A lumbar drain. Okay.
But at the end of the case, but they were happy with our repair. And he healed just fine.
Dr. Monroe, Dr. Schmalbeck, or any other experts on the panel, would you guys have neurosurgery involved in a case like this?
I live in the city of Philadelphia, which is highly litigious, so absolutely. Plus, I just really value their skill set as well. So we would.
Yeah.
Yeah, certainly if we saw any bony erosion around the base of the skull, we would. And we have a very good working relationship with our neurosurgery team. So if we ever need them, they're usually just a short distance away.
I mean, I learned my lesson the wrong way, where I regretted not having them know. So at least for a superior orbital tumor, at least let neurosurgery know, especially if I'm removing any bone around that area.
I would love to hear maybe from the panelists or members at large their approach to reconstructing the orbit. And really two questions. One, reconstructing the orbit, particularly when your resection extends into the nasal cavity, nasal and sinus cavity. And the reason I say that is I think these are reconstructions that have a high risk of developing a sinocutaneous fistula around kind of the medial canthal region. If you don't do something to block off kind of the nasal cavity. So I'm curious if anybody uses forearm is a very common choice, but curious if people use other flaps with larger bulk and when they choose to use that.
Well, for me, I'll just start. I completely agree that if it's into the nasal cavity, I absolutely add a free flap. So if it's not into the nasal cavity, you could consider a skin graft reconstruction, especially if they're not going to get radiation afterwards. And that probably is the best reconstruction in terms of orbital implants, orbital prosthesis, which we usually put orbital implants to for the prosthetic. But if it's into the nasal cavity, I'll sometimes see if I can use skin, like the native skin, to have a thinner rim over the implants, and then I definitely put free flap superiorly and medially. What I worry about also is if an inadvertent CSF leak, which I guess in my hands happens not that often. And they're, usually not a big deal in neurosurgery compare. It's usually just a small tear, even just, doing your nasal osteotomies, they can happen. The skull base, especially in an older person, is so thin. And if that happens, I want to have my free flap there to support it. And they can avoid craniotomy. Any other comments on anybody else on the panel? or at large?
Okay. Okay. Um,
Okay. I need more to your presentation, Solimar?
just that he's doing well.
Oh, great.
We usually do put other orbital implants as well. We have very close relationship with maxillofacial prosthodontics, but in this case, this gentleman did not care about his cosmesis at all. He just wanted the cancer out.
Well, I think, in a way it made his decision easier. He already had radiation. He already had vismodegib, and accepting it was pretty good. Um, any concern for any consideration of orbital? I guess he didn't care about his appearance, but would other people do orbital implants routinely in these cases? Or any consideration about orbital implants?
Like I said, just to clarify, we have a maxillofacial prosthodontist as part of our department, so we actually implant almost all of our patients in general. But
Mhm.
this gentleman, particularly, he just didn't care
Didn't
for
want
it.
it.
Yeah.
Okay. Yeah, one thing that I have sometimes done is just bury the implants under the free flap, and then just in case they ever want it. But I have to admit that some people just never ever want it. They never want to care for it. They don't care about the prosthesis.
I'd say we don't do it routinely just because our anaplastologist who makes our orbital implants generally will use other methods first, and we do it in a delayed fashion if the patients want it, which is we certainly, or for whatever reason, I don't know why it is, we are more aggressive about placing implants at the time for total auricular defects, or even into the mandible for dental restoration. But this is one where we usually wait. I don't think there's a good reason for that. That's just the way it happens.
I will say sometimes I feel like it's easier when everything's open, like everything's wide open. Um, okay, well, that was excellent. Any other comments? Thank you for three very great discussions, and thank you, Dr. Monroe. Thank you, Dr. Schmalbach, Dr. Kane. I hope the abscess is doing better. And and then I'm sorry Dr. Adebayo wasn't able to join us. Thanks for joining last minute, Cecilia. I really appreciate it.
Oh, my pleasure. Great cases. I
Yeah.
really appreciated joining.
Yeah, same. Thanks for the opportunity.
Thank
Thanks,
you.
everybody.
Bye, everyone.
Night.